Okay. Okay, everyone. Second time's the charm. Welcome again to the continuation of the Midwest Culturally Inclusive Conference. The session this evening is entitled Bias in Healthcare, Access and Algorithms. We do have some community standards during the Midwest Culturally Inclusive Conference. I'm going to verbalize a few of them, and Kaden will share our full community standard statement in the chat. Please obtain consent before taking any photos of anyone in the session tonight or screenshots of content that is not your own. If you're here for a class or professional development, it's completely fine to take notes or jot things down. We just don't want to be sharing content that isn't our own. The session is a little bit different tonight, as you can tell. We are doing a webinar version, and so you actually are all already muted, and you can't unmute yourself, but please feel free to still interact and engage with the chat. We are using a live closed captioning service, and I'm going to talk a little bit more about that in a second here. If you do not already see a black box in your screen that is showing the text that I'm speaking, you can bring this up on your end by locating the More button, and you're going to want to click CC and click Enable Live Transcript. You can message us in the Zoom chat still if you're having any difficulties with this or anything else in tonight's session. Most of the recordings for the most of the sessions for the Midwest Culturally Inclusive Conference will be recorded. This QR code on your screen links directly to the Campus Climate YouTube page. I am in the process of uploading some of our sessions from last week as we speak. Most of the sessions are being recorded to make it as accessible as possible for those who cannot attend live. We will be posting an announcement in Whova when those recordings are posted. And like I said, they will live on our Campus Climate YouTube page. Finally, if you have any questions tonight or throughout the month, please utilize the Zoom chat, either publicly or privately. We have a couple of co-hosts this evening. If you have questions about the session or anything else, please message us there. Additionally, our Campus Climate email account is constantly monitored as well, so you can email us now or at any time. And finally, I would like to introduce tonight's session, Bias in Healthcare, Access and Algorithms, which is hosted by J Dhyanchand. The U.S. healthcare system has many strengths and weaknesses. The longstanding access issues in low-income urban environments are well documented and have worsened over time, disproportionately affecting Black and Brown communities. More recently, these issues have become more pronounced in small, rural, mostly white communities. Using recent research from author Heather McGhee, I'll explore some of the systemic reasons for this growing disparity in these seemingly unrelated communities. Additionally, I'll highlight some of the systemic ways that algorithms in clinical medicine have exacerbated racial biases. I will now turn things over to Rich.
Great. Thanks, Emily. I'm going to go ahead and share my screen. And I think you can all see right now. So yeah, thank you. I'm not sure how this is going to go, but we'll, you know, I thought it would be useful to kind of summarize some of the stuff that I've been thinking about and working on in a variety of different places over the last year in particular, but even going back a little bit further. So as the summary that Emily just said is pretty accurate to what I intend to kind of discuss and talk about today. My goal with this once upon a time was to try to make a seamless transition between these two topics, and that proved to be a little bit disjointed and awkward. So instead, there's going to be this hard pivot at one point as we kind of switch to a different topic. But please do, as she said, throw any questions out into the chat. I'm not guaranteeing that I'll answer them immediately, but there should be sufficient time towards the end of this for me to be able to answer questions to the best of my ability and talk about a variety of, I guess, try to address the questions that you might have. So we'll get started by first, again, I'm trying to discuss two topics here. So one is the idea with regards to racial bias in the US healthcare system, access to care. And there's been some really well-documented data over time about issues with regards to access. But I like some recent things that I've looked at that really kind of paint it in a slightly different light that allows us to kind of even draw connections to really our place, meaning living in rural communities throughout America, which are very different than your traditional places where we see access issues occurring historically. And the other thing is just some institutionalized algorithms that exist that I kind of was brought up in many ways in my own training and my own education. And so I wanted to kind of address some of that as well, because it was kind of eye-opening when some of this stuff occurred to me. So the first thing I want to talk about is, you're probably wondering, am I qualified to talk about any of this? And honestly, I'm not sure that I am, but this is who I am anyway. I put a picture of myself in here. So who am I? I started off as a math major is what I did undergrad, which makes you think, well, why on earth is he talking about healthcare? I went on after medicine to do some studying in public health, specifically epidemiology. I did some research during that time at Cook County Hospital. If you're not familiar with that, that's a hospital in downtown Chicago, County Hospital. It was the basis of that show ER back in the day. Spent some time in the emergency room there, working with patients on chest pain and asthma studies, so mostly working with kind of low-income African-American population in that study. From there, I went to medical school. From there, I went to do vision research. I didn't practice like most folks that go to do medicine. I actually ended up finding a different path entirely. Did vision research up at UW-Madison for a while. That was more like basic science research in glaucoma. Made another different kind of hard turn and went into sales and marketing for Pfizer Pharmaceuticals for a while. Learned a lot about the business of healthcare. And then more recently, made yet a different turn. And when I say recently, I'm referring to the last 15 years, where I shift to undergraduate teaching and advising. So a lot of what I do here at UW-Platteville is teaching healthcare students interested in that pre-healthcare kind of track, especially medical school, PA school, and doing the human biology kind of stuff, anatomy, physiology, among classes that I'm involved with teaching. The advising piece is definitely in terms of advising them in the courses they need to take, but also in regards to career track and direction. It's something I'm extremely passionate about. I put PUMP in there. PUMP is an acronym that we've come up with called Preparing Undergraduate Medical Professionals. And it's our new kind of revamped small group discussion that we do with the students that are interested in the healthcare career. It's kind of a selective process to get students to join PUMP. And in PUMP, I wanted to mention that here specifically because what I'm about to kind of lay out for you are some of the things that we have talked about in our PUMP discussion groups. Just as a side note, I initially wanted creating responsible medical professionals, but nobody liked cramp. I took that, I guess, for what it was, and I agreed to PUMP. beyond the teaching and advising, I also have some really, I guess, broad healthcare interests. Over the last decade, I've been involved with the regional and statewide, what we call area health education center. So it's a nonprofit organization that tries to develop interest in healthcare careers, and the AHECs are national organizations. I've been doing it more locally. I'm currently president of our regional AHEC and serve on an advisory board for the state. And then more recently also have been on the hospital board at a local hospital. And that's been a very eye-opening experience for me to learn more about that business side of healthcare management, and especially during the pandemic, where I've been, that's my tenure with the Grant Regional Hospitals Board has been during this whole time. So I want to start by going just back a few years in time to when some of these ideas kind of came to me. Several years ago, I took a sabbatical. It was in fall 2018. And the whole idea there was I was planning a short-term faculty-led trip to just kind of expose our students to aspects of the Indian healthcare system. So I made a trip over there, made all these plans to do things, and then we had this pandemic that I think was a plot to keep me from taking students to India. And so I wasn't able to do that trip as planned. Now, also while on this trip, sabbaticals gave me a break from doing things. Now, this is a back burner thing, the study abroad trip. I hope that in the next couple of years, right now, India is not the best place to, and I don't feel comfortable recruiting students to go on a trip like that right now, but I hope to resume that and do it as a winterim trip in the future. I also had a lot of time during that time to do some thinking and reading and do what I do a lot of, which is listening to podcasts and walking my dog. And it was during that I came to know, that was where I first got to know Ezra Klein. And so back then, Ezra Klein was one of the founders of Vox Media, and he has a podcast. He's now with the New York Times, and I became a pretty avid listener to his for really over the past 5-6 years, listening to his podcast pretty regularly. And a lot of the people that he interviews have kind of shaped a lot of my other reading over that time. Last year, I heard his second interview with a woman named Heather McGhee. Heather McGhee used to work for a think tank called Demos, kind of a more progressive, social justice kind of organization, especially focused on like economic disparities. And he interviewed her about her book called The Sum of Us: What Racism Costs Everyone and How We Can Prosper Together. I have purchased over the years several copies of the book, have given it out to quite a few people. It was one of those books when I found it extremely persuasive. When I first listened to the interview, I was like, oh, this is quite interesting. I should, get this book. So I do a lot more downloading of books and listening to it. So I downloaded and listened to this book. And it was one of those moments where, a lot of things that she was talking about made a lot of things that I was seeing and experiencing click. And she does a great job of using like tangible data, history, and then weaves that in with a lot of like personal anecdotes and stories of her youth growing up in Chicago to support the premise of her book, which I'll touch on in a minute. So I've kind of become a bit of a Heather McGhee evangelist over the years. I think she was one of the names that I submitted for our speaker for our distinguished lecturer for this year. I saw her name made it to like a short list at one point, so I was happy to see that. So the premise of her book, there's kind of two big pieces that you see in the book, and the first thing is this idea of this zero-sum nature that we live in, and which she would refer to as a zero-sum fallacy. The idea here is that we believe that there's only so much, and if somebody else is going to succeed, then they're going to succeed at the expense of somebody else. And this is used as a regular, how would I say, way to try to motivate people to other a different group, and to say, well, we don't want them to do well, because if they do well, that's at the expense of us doing well. And this has been a big part of how immigrant communities, as well as Black and Brown communities, have been treated in the United States for a huge amount of time, right? And so she kind of points to that fallacy as being kind of a basis of how a lot of things are unfortunately viewed by many people in our society, that and people slip into that, and they very easily start, we see it all the time in the past few years, especially with, well, this immigrant community is going to impact this or that. And so that's one of the premises that she kind of refutes throughout the book. And then the other thing is she uses the story of public swimming pools to try to address what she would refer to as like drained pool politics. So I found this, it's a very persuasive and very interesting story. The idea that once upon a time, which is very true when we're talking in the, let's say 100 years ago, or less than that, even going into the, the 60s and 50s, 60s, 1950s, 1960s, where there were a lot of public pools. Public pools were everywhere. They were kind of the pillars of many communities, but they were also segregated. And then when things changed, and then we had to, there was a forced integration of a variety of entities like the public pools. What a lot of communities decided to do at that time was, instead of integrating pools and sharing that resource with Black and Brown individuals within their own communities, they would rather just get rid of them. So they would all sorts of different things, pour cement in them, tear them out, sell them to a private entity for $1, or just simply shut them down. And the neat thing that she then says is, yes, and that definitely impacts, has negative impacts on the people who would use that pool, right? So now no Black and Brown individuals could attend those pools, but it also impacts a lot of poor white communities as well. And that was one of the things that I found most interesting about her book, is that throughout it, she uses that story to then overlay that same type of, well, we don't want to share with this group, so we're willing to sacrifice sharing with this other group as well, and weaves this wonderful story where she looks at housing, and she looks at education, and she looks at healthcare, and like I said, while there's negative impacts on poor Black and Brown communities, it also does affect a lot of poor white communities, and we could, this is where we live. This is rural communities as well, that are now struggling with a lot of these same things, decades later. And so her analysis really puts this kind of different spin on it. And I I really like that. It actually, I'm not going to get into some of the latter parts of the book where she does talk about some of the neat solutions. I'd be happy to talk about some of those separately in like a Q&A type time. And then some of the solutions that I already see being implemented on some level locally, which is really quite neat to see. So I'm going to focus by doing a couple slides where I'm going to talk about universal health care coverage and summarize the section in the book where she addresses this and weave into that some of just other knowledge that I have about universal health care and where we are with some of that right now and the quest for getting universal health care in the United States. The first time that in the US we tried to get universal health care coverage was back in the 1950s under President Harry Truman. There was a senator by the name of Claude Pepper, who was a Democrat from Florida, which Democrat from Florida sounds super strange these days, but it's a very different time that we're talking about. And he was a champion for trying to get universal health care coverage in the United States. There was significant resistance that he was met with in doing this, and I think Pepper was he's a senator. I think he was originally farm guy, supposedly like a big red-haired guy from rural Alabama, and he just felt that this was a very important issue that we should be moving towards. I'll also preface, this was at a time when employer-sponsored healthcare was not a big thing. This was trying to figure out a way to help people get better healthcare coverage was my understanding of what he was trying to do. Now, the biggest resistance that he was getting was coming from a couple places. One was coming from the American Medical Association. The AMA labeled his plan as a socialist plan, and that we shouldn't be doing this, and you still see some of these you still see some of this argument being made these days for some of this, and as you kind of look at this, you'll maybe some of this will echo as still being true today. There was a lot of wealthy Southern businessmen that started using race to kind of get him out of his position. So a huge campaign tying him to members of the African American community. Every picture that they could find of him with prominent African Americans, actors, and such were being put up, and then they also started using claims that that there was a lot of misrepresentation of voting that was happening, that they were claiming that northern kind of labor unions were getting involved and paying to register Black voters. None of this was shown to be true at all, but the plans worked, and he lost re-election in the 1950s, and as a result, Truman lost his champion in the legislative branch in the Senate to help develop this universal health care plan, which was a plan that Harry Truman was quite interested in trying to bring to fruition. He left office, I think, at 52, and when he left office, he couldn't. This was one thing that he never could really get to happen. One of the interesting things is that these plans, using that kind of racialization that they did, most of the benefits would have benefited white Americans back then. They were very, very, definitely they were the largest population that existed at that time frame, and it would have. But the idea is that sharing this pool, it doomed the plan early on, that people were more interested in kind of not doing that, and as a result, it ended. So universal healthcare, it wasn't in my lifetime, I've been hearing talks of let's do universal health care, and we never seem to get there. And it's been going on for quite a while. The next big kind of major healthcare change that took place with regards to access in the United States happened under the Johnson administration in the 60s, where now they instituted Medicare and Medicaid. I don't want to assume that everybody knows the difference between Medicare and Medicaid, so I'll just kind of mention them and talk a little bit about them. But Medicare is an incredibly popular plan right now, and Medicare is a plan that is for elderly population, which at the time that this was being instituted was mostly white population. It received federal funding and was, there was a lot of resistance in some groups, but the passing happened. It's now incredibly popular now. At the same time, Medicaid was brought forward. Now, Medicaid is more for your poor individuals. I'm just using the word poor. It's a lot more nuanced than that. But it is a more diverse population at the time that would have benefited from Medicaid. She argues in the book that part of the reason it didn't get the federal funding and instead was, well, let's let states decide how they were going to fund it and run it, or in many situations underfund it. It never really has done as well as Medicare has, both in popularity and the benefits that it receives. I mean, still today, depending on the state that you're in, Medicaid is incredibly we'll go into some of the details, but the ability to qualify for Medicaid, it varies so much from state to state. And the reimbursement piece for hospitals and for providers is extremely low as well, making it so that many providers, don't want to treat patients that are they put caps on the amount of Medicaid patients that they might treat or see. Later on, and so this is in recent times and in my lifetime, we're talking about Medicaid expansion. So the ACA, or the Affordable Care Act, also known as Obamacare, that came about in 2010. What the ACA did was a lot of different things. I mean, I think a lot of people, interestingly, there's still a huge number of people that are very against the Affordable Care Act and against different, but when you break it down into some of the individual benefits that are there, people will be like, yeah, I think pre-existing conditions should be covered. They're for that, or they're for rescission. This idea that you can't, dig through somebody's insurance plan or, and see if they lied somewhere in their application and then say, well, you lied, you had depression and you took some drugs for this at one time, so we're not going to cover you for this, because that was a practice that was pretty commonplace, I'd say 10 years ago over 10 years ago before the ACA. So there's a lot of individual benefits in there that I think most people like, but by and large, there's a lot of people, especially on that are more Republican, and in her book she kind of goes into this, that more among white individuals, the ACA has never quite hit 50% of approval. But when you split it up into individual bits, people like a lot of the individual bits, but they seem to not like the whole package. So one of the things that was part of the ACA is the idea of expanding Medicaid. So I referenced Medicaid previously in the previous slide, and what Medicaid did with regards to it's run by different states, and there's a lot of variability in how Medicaid works. For those of you who aren't familiar with it, in Wisconsin, it's called Badger Care here. It's it's different names in different places. But the idea with Medicaid expansion is that they would then make federal funds available. And if you opted in, you would get better funding and better resources to cover this patient population, to afford better insurance for them. But what happened is that many state legislatures refused to do this and refused to do it for all sorts of different reasons. But the lines were drawn very hard with certain, political tendencies of the legislative branches in the different states at the time. Right now, and so these are some numbers that are somewhat shocking. So in order to qualify for Medicaid in the states I've listed here, so in 2020, that was you couldn't have earned more than those numbers in those states. You had to earn less than that in order to qualify for Medicaid. There's a typo in the Florida one. There's 2 3s in there that shouldn't be there. So your income would have to be, in essence, less than $7,600 in Georgia. This is for a family's income. So parents with, I think we're looking at parents with 2 3 kids here, but income would have to be extremely low to even qualify. In essence, nobody's qualifying for Medicaid in these states. Wisconsin even made the decision back when Scott Walker was the governor here to not fully expand. If they expanded, they would receive and get the federal funding. They would receive a 90% match on from federal funds, but we're only receiving a little less than 59% now. As a side note, COVID was kind of an interesting mix and really changed things a bit here. With COVID, while I think most of us that are paying attention to things surrounding COVID are very aware of what's been happening with regards to the disease, but what's been happening in hospitals has been very, very interesting. It's actually helped in different ways. A lot of rural hospitals are doing very well financially right now. If they're seeing patients, obviously that's generating revenue. We don't like to think of it as a guy who was trained in healthcare. It's hard for me to feel like that's a good thing, that we're, treating patients and we're making money for that. But that's a separate discussion on how we reimburse and that piece. But there was a lot of federal funding that came in to especially rural hospitals over the last few years, where they were quite flush with a lot of money. And actually this match, because of the federal funding that they were in essence had to take, it went up to 66%. It actually has allowed for hospitals to do a lot of different things. If you look closely at what a lot of the area hospitals are doing, there's a lot of expansion happening. There is land being bought, there's clinics being built, and it's just kind of a fascinating to me thing that's kind of happening with that. That said, to come back to this piece here, that by not funding Medicaid, this dramatically impacts rural hospitals. Now, why does it really impact rural hospitals? Right now, in most of the rural hospitals in and around here, hugely dependent on Medicare and Medicaid as their primary payers. When you get into a situation where the primary payers for a hospital system are Medicare and Medicaid, and it's over 50% or more, which it kind of is, you're not getting you get more money from private pay insurance. The thing is, there aren't as many people around here that have private pay insurance. I think UW-Platteville has, it's a good place to work. We have decent insurance, and a lot of people like our employees to come to their places of business or to their clinics and hospitals because we have good insurance. But if the majority of your patients are Medicare or Medicaid, it ends up really reducing the income for that hospital and impacts their bottom line significantly. And not to mention that, and as a result, a lot of hospitals are reducing the service lines that they can offer, are shutting down entirely. I'm hopeful that that doesn't happen in this area. I think it won't happen right now for a while, but there's still a lot of concern about that. And rural hospitals get some special kind of funding anyway, but it is this whole thing. It has a huge impact on rural hospitals. So the point being that, to kind of tie it back to what she writes about in the book, it's a complicated thing, but her argument is that because the history is there of we're not wanting to be in the same pool as this group of people, and as a result, it's impacting more than that group of people. Okay, so that takes me through like kind of the first section that I was talking about just the bias in the system and that link between the rural and more historically inner city urban kind of settings. The next thing I wanted to address this was an interesting one to me, because having gone through medical school, having been trained in different ways on, well, you use this drug for this patient in this situation. I mean, that was the kind of stuff that you learned, and that, just like with anything, you just kind of take it for what it is. One of my colleagues, she chose an article from Science, well, actually from Nature magazine, that was doing a thing from Science, and it looked at the bias that was taking place in medical algorithms. So when we're talking about algorithms, we're talking about some sort of decision-making process, but specifically we're talking about like software type algorithms that are created. And what they did was they found that they were actually less likely to refer Black than white patients when they were equally sick. And the idea being that these algorithms are computer algorithms that are written by somebody, written by a software engineer, and they're used by hospitals, they're used by insurers. And so fascinating, it was made it so that two patients that had the same level of healthcare or were equally sick, and when you were trying to do a referral for them, the computer algorithm that was used would then recommend, well, this person would be more likely to get this treatment option and this treatment option. And what it came down to was Black patients were less likely to be referred for more personalized care than the same white counterpart. Now, I'm not going into the details on the mechanisms that they use, but the idea being that there was systemic bias that was written into the software, and they make the argument that, and this is important for, training the people that are writing these kind of algorithms to do different, to have some sensitivity on like what kind of things that they're looking, what are the downstream effects of writing a program that does things in a certain way. Now, I mentioned this because we discussed it in our pump discussion group, which led me to then, after reading this, my brother's a family doc in Ohio, and I was kind of talking to him because I was like, what, this seems really weird, and so he happened to be attending that week continuing medical education conference online in a Zoom format, but it was being put on by Harvard University, and they were discussing a different bias paper that was published in the New England Journal of Medicine that looked at the role of race in treating patients, and I found this also similarly fascinating, because what was happening, what they showed is that they're, and the weird thing is, like, I can attest to having learned some of these things. I mean, these are things that I was taught, and I just took to be, well, this is how we do things because this is what I was, somebody somewhere told me that this is the way that we should be prescribing these medicines or such. And so the thing is, like, a lot of them are based on older studies that still pointed to these major genetic differences between specifically Black and white populations. And the kind of things that it ends up impacting that they laid out in the New England Journal review article was that it would impact, for example, the use of different drugs when you're treating hypertension. Like, I learned that, well, you use an ACE inhibitor on African American, it's important to use that there versus here. And when you do some digging and trying, at first it's hard to try to figure out where the basis of some of these drug treatments are. So I use the phrase ACE inhibitor. That's just a type of medication that is used to treat hypertension. There's a bunch of different classes of them, but we were always taught, well, this is what you use in an African American population versus others. The American Heart Association has a additional score that they've always had in there, in my knowledge, to assess the risk of heart failure. If you're African American, they add 3 points. And this makes it less likely that you will actually be referred for a cardiology consult in a hospital. So it changes the way that you get treated from a specialist. Another one, estimated GFR, a glomerular filtration rate, or GFR, is one of the blood marker or blood tests that can be done to estimate your kidney function. They have a different way of looking at that, and they actually do have a factor in there that says, what's your estimated GFR and what's your estimated GFR if you're Black? And it has a huge impact on changing things like access to transplant. So now there are people not getting qualified or not meeting the criteria needed to get a kidney transplant because they lack that, their score puts them out of that ballpark. And then the last one I'll mention here is VBAC success. VBAC is vaginal birth after cesarean section. The scoring used to assess success of doing a vaginal birth delivery after the patient has already had a C-section in a previous delivery is skewed to show that there's low success in African American or Hispanic populations, shifting it so that they're almost much more likely to get another C-section where it might not necessarily be even warranted. So a lot of strange kind of, and it's, I like that they're bringing these things up. I like that these are things being discussed at a CME conference that my brother attends. I like that we're talking with our students about these things, because all of that works towards us in time being able to make some dramatic changes into how we approach more holistic treatment of patients. The GFR one to me is kind of funny. I actually just pulled, this is from my mom's My Chart. I asked her if I could put this out there, and so this, like, you can see it's right there, the component. They have two different GFRs that you're looking at to assess kidney function there. So those are the things that I have to kind of chat about. I think there's some time for some questions, so I haven't looked at the chat or anything. So if there's anything that you guys want to have me answer, I'd be happy to.
Yeah, folks want to utilize the chat. I see that.
I'm going to go ahead and I'm going to stop my share too. So.
Okay. Yeah, and there's still the raise your hand function. So people have questions for Rich. Yeah, go ahead and share them.
Rich, did Heather's book have any suggestions for how to start removing some of that bias out of the healthcare system?
One of the things that she, I think the thing that I like the most about her book is that when I talk to my student population, I find that lots of times, that they just haven't had certain experiences, right? They don't have many friends that have, dealt with some of these, some of the, situations that, are kind of talking about there. So by being able to bring it back and say, well, this thing that is happening, and this is one thing I like about, over the years I've been here, we've been doing things where we're looking at different underserved populations, and the similarities between rural settings and urban settings there are actually a lot more common. So there's a lot more common there than you think on the surface. So by referencing that these issues that have been in this population are now very prevalent in the populations that we're in now, I think is really important. And one of the solutions, to kind of get to your question, that she offers is one where she, some of the rural communities that are struggling, many are struggling, population is an issue, jobs are an issue, all of these things are, challenges. But one thing that she brings up is the importance of a lot of rural communities, actually, especially rural white communities, trying to do a better job of integrating with and working with immigrant populations that have come in more recently. Around here, it would definitely be that Hispanic migrant worker type population, right? And Darlington has done a great job of this. And very recently, I think there's so I'll speak specifically to something happening in Lancaster right now that, she, in the book, she talks about all these different areas, where they've welcomed a Somali community or a different, whatever community it is, and how, it's not perfect. It's not like everybody gets together and, and it's a, these two cultures weave together and everything's perfect and we kind of move on. But instead, it's more trying to figure out how to work together and how to work with each other. The Grant Regional has, I'm proud of this. I'm proud to say that I'm, part of that organization, because they've reached out and they have a new fellow coming in who's going to be a family physician there starting this summer, who is from Mexico, finishing his residency doing family medicine. He's going to be covering everything from birth to death. And they personally want to use him as a resource to try to engage with a different patient population that we've come to realize recently doesn't really come to Lancaster, doesn't choose Lancaster as a place to go, because talking to a lot of area farmers, we've come to learn that their workers would actually prefer to go somewhere else, like Platteville or Darlington, for their shopping. So there is a group that's been meeting now, about 5-6 meetings up in Lancaster, and I'll just call it kind of a Latinx community engagement group. And it includes all sorts of businesses from the area, includes people from the university here, like Lehman, Haviland, and I've been attending the meetings, and it's kind of neat to me. I'm not saying that Heather McGhee motivated this, but it's one of the solutions that she points to. And when they mentioned that they were doing this, I then gave me an opportunity to evangelize for Heather again. So
you have 2 other questions, Rich. One of them is, do you know any information regarding restricting pain meds to many Black folks based on the belief that Black people feel less pain than white people?
Yeah, I know that's a thing. We actually read a similar study in our reviewing this, that that is something that unfortunately is happening, but or has happened historically. So I think the shift is there to kind of move away from some of that, at least at the level of the algorithms that are doing that. But to get the individual providers to maybe do less of that, that's going to take some time. As I tell my students, I'm hopeful that that'll all change, because they're going to be providers soon, and that'll be a good thing. So.
Thank you. The next question you have is, has there been significant communication to local legislators regarding accepting Medicare and Medicaid funding by regional healthcare organizations and/or rural patient pools?
I don't know the answer to that question. I think that there has been a push by some groups to try to do that. I find that it depends on the organization, and it depends on the people. I can write letters, we can write letters. I don't know how much weight that carries sometimes. I think when you get it from leadership in different area hospitals, in different clinics and such, that might carry a lot more weight. But I think that I think some people in those positions aren't bought in that this is an important or valuable thing. They would probably feel very, very different about doing that. But I'll say that the legislators have heard some stuff from me. So.
All right, do you have another question? Would we find the same types of biased decision-making in allied health fields? Has the research been extended to look at all fields of healthcare?
So when we're talking about allied health, can you be a little bit more specific about what we're referring to there? Are we thinking like physical therapy? Are we thinking dentist, PT?
Dentist,
Yep.
yeah.
Yeah. So yeah, I would yeah, to those specifically, I've seen some data on PT, and both the referrals are down for physical therapy, and also that there's well, I guess I'll just stick with like that. I see referrals are down for in the realm of PT, and possibly even the type of PT or the amount of treatment that they're there. The dentistry thing is a really interesting one, because dental care is not covered very well by much of anything. Medicaid reimbursement, or Badger Care reimbursement for dental care basically doesn't exist, and because of the way dentistry is treated so differently than the rest of your body, as if the teeth aren't part of your body, it becomes a real difficult. People, a lot of dentists don't want to deal with the taking on the Medicaid population in general. So I think they'll do it pro bono here and there. Up in Cashton, there's the Scenic Bluffs community clinic, and Scenic Bluffs says, I think they've had a posting for a dentist. I know the former head of that organization was on a board with me, and they've had a posting for a dentist there for at least 6 years. They haven't been able to fill. So there's just a lot of problems with kind of filling that. And then on top of that, insurance doesn't pay for so many things associated with your mouth. People don't have good dental coverage. I mean, this even goes for Medicare patients, don't have good dental coverage. So as far as the bias that is there, I don't know fully, because I think the bias exists at the level that the care doesn't exist.
Another question Socialism is a term that most Americans don't understand, but all Americans are taught to hate. Do you think that the labeling of universal healthcare as socialist makes resistance to it in the US so prevalent?
Yes. Yeah, I mean, I'll be very short with that answer. I mean, it's, I found it quite funny to be reading the labels that the initial push for healthcare at a universal level back in the 40s and 50s was being labeled as socialist. At a time when private insurance wasn't even a commonplace thing. It was just and then you kind of come back to it and use it again in 2020, right? So I just think it's unfortunate. I wish that a rebranding could happen, because unfortunately I think people just are so ingrained in what they think that means.
Thank you so much, Rich. I don't see any other questions, and we are right on time. So I don't know if there's anything else you want to share. I'll keep looking for any last minute questions, but yeah, great timing.
Yeah. So, well, yeah, no, I thank you. Thanks for letting me do this. If any of you have any questions, I mean, this is stuff I like to think about and talk about. So if any of you that are out there in the attendee roster and such, you can get a hold of me. I'd be happy to chat more about some of these topics. But yeah, it's so thank you.
Yeah, and thank you all for being here. We have 2 more sessions taking place tomorrow, so we hope that you join us and have a great rest of your evening.